So rheumatic heart disease and mitral stenosis. Just a second. Yeah. Mitral stenosis is the narrowing of the mitral valve orifice, leading to obstructed blood flow from the left atrium to the left ventricle during diastole. It is more so present in the developing countries, and the women are more affected compared to men. Onset is usually in the third and the fourth decade of life. So the stenosis will be there of the mitral valve, where there is narrowing and blocking of the blood flow coming into the left ventricle. Etiology: the rheumatic heart disease is the first etiology. It is a preventable sequelae of the acute rheumatic fever. Post group A streptococcus pharyngitis, and mitral stenosis is the most common lesion here, progressing to LV inflow obstruction with pulmonary vascular consequence. Other causes include calcific disease, for example, mitral annular calcification, prosthetic valve dysfunction, systemic inflammatory disorders, radiation valvulitis, endocarditis with large vegetations, congenital causes, and carcinoid. So, what is the pathophysiology in case of a rheumatic heart disease for the mitral stenosis? It is the untreated or undertreated group A streptococcal pharyngitis, okay, and it occurs as a result of an exaggerated immune response to specific bacterial epitopes in the susceptible host. The inflammatory process in the valve leaflets is thought to be initiated by cross reactivity between the streptococcal antigen and the valve tissue. So essentially, this thing is called as molecular mimicry. Okay, where the M protein epitopes resemble the cardiac tissue, and it leads to the pancreatitis, recurrent episodes, valvulitis, and fibrosis towards the end. Valve deformation can happen, leading to thickening of the leaflet, commissural fusion, caudal shortening, which causes the fish mouth orifice and calcification of the leaflet cusps. So, in case of mitral stenosis, exactly what happens? There is pressure in the left atrium. Because of the stenosis, the flow into the left ventricle is not happening properly, and there is a pressure. The volume increases in the left atrium, resulting in increase in the pressure, because of which there is a backflow, and there is increase in the progressive pressures in the pulmonary vasculature. A further back pressure leads to the right ventricular pressure overload, right ventricular dilation, leading to these problems. And for the left ventricle, whenever there is a left ventricular pressure overload, LA dilation happens, it can lead to all these problems. So, what will the patient present with? Patient can present with, initially, he will be asymptomatic, but later on can develop symptoms of heart failure, progressive exertional dyspnea. Atrial fibrillation symptoms might also be present. Okay, and a patient can come with what is called as Ortner syndrome, where there is compression of the left recurrent laryngeal nerve. They can present with cough as well as dysphagia. Any cause of increased cardiac output can further lead to worsening of this condition because of reduce in the diastole. So, what kind of murmur the patient presents with? They present with a low-pitched mid-diastolic rumbling murmur along with pre-systolic accentuation, opening snap, okay, after S2, which is heard best at the apex, and the murmur increases with squatting and hand grip. It decreases with decreased blood flow across the valve. Opening snap becomes closer to S2 as the stenosis becomes more severe, and the opening snap might be absent if the valve is heavily calcified. Apart from that, patient also present with mitral the facies of the mitral facies, central cyanosis with developing of pulmonary hypertension, low volume irregular pulse, pulmonary regurgitation with Graham steel murmur, which is present during inspiration, and all the signs of heart failure patient can present with. Diagnosis: the ECG features comprises of P mitral, which is the left atrial enlargement, which is the classic ECG manifestation. Apart from that, they can also present with features of atrial fibrillation and sometimes pulmonary hypertension. Chest X-ray comprises of straightening of the left heart border, prominence of the upper lobe veins, pulmonary artery enlargement, curly B lines, which is relevant of interstitial edema, presence of McCullum's patch, which is the the large LA, which is visible as a double shadow, and LA calcification. Right heart catheterization, there will be presence of giant A waves whenever we do a right heart catheterization, and the PAC tracings will be like this. Echocardiography. Now, there is a huge chart of echocardiography definition and the anatomy and hemodynamics given. So it has been cut short, and we have to remember only three things basically. So the mild mitral stenosis is when the mitral valve area is more than 1.5 centimeters square, but the mean gradient is less than 5 millimeter of mercury. It is mild. Uh, it is moderate when the valve area is 1 to 1.5 centimeters square with a mean gradient of 5 to 10 millimeter mercury. And it is severe, which can be divided into asymptomatic and symptomatic. So severe is when it is less than 1 centimeter square with a mean gradient of more than 10 millimeter of mercury. And there is also something called as critical mitral stenosis, where the valve area is less than 0.5 centimeter square. So, how do we manage mitral stenosis? Any underlying pathology which aggravates the condition has to be treated. Secondary prevention is important, like penicillin G. Okay, all the things which presentations of heart failure, any cardiogenic pulmonary edema, they have to be managed. Non-invasive ventilation, intubation needs to be done for the patient. So, atrial fibrillation is poorly tolerated in this patient, and emergent cardioversion might be required. Potential complications in such patients include death, stroke, cardiac perforation, severe mitral regurgitation requiring cardiothoracic surgery. Residual atrial septal defect may also require closure. Anticoagulation is indicated in cases where there is persistent AF along with mitral stenosis, prior embolic event, or presence of a left atrial thrombus along with mitral stenosis. Here, warfarin is preferred over the direct oral anticoagulants, as is depicted in the Invictus study, where it was found to decrease stroke and death in such patients. Digoxin, beta blockers, calcium channel blockers might be required in such cases, and diuresis is required to manage the pulmonary congestion. DDs include left atrial myxoma, endocarditis, mitral valve prolapse, severe AR, tricuspid stenosis. Where will we do percutaneous mitral balloon valvotomy or commissurotomy? So it will be done in the following cases: where there is severe MS, favorable valve morphology, absence of left atrial thrombus or moderate to severe MR, and patients coming with one of the following symptoms: where there is severe symptomatic MS, asymptomatic MS but a mitral valve area of less than 1 centimeter square, new onset of atrial fibrillation, or suboptimal valve anatomy. That means the patient is not yet a candidate for surgery. And mitral valve replacement in other cases are done. Here, anticoagulation is required for 3 to 6 months for bioprosthetic valve and lifelong for the mechanical valve. So, goals: avoid tachycardia, maintain preload but do not overload, cautious diuresis is required. Afterload in hypotension, patient will require agents, but it should not cause too much of tachycardia. Okay, atrial fibrillation rate control will be needed, and if need be, patient needs to go for an urgent cardioversion. High PEEP can worsen the RV effect, as we have discussed yesterday. Okay, so use the lowest effective PEEP. Intubation induction if needed. Blunt the sympathetic surge. Avoid drugs like ketamine, which can cause tachycardia. If required, use more hemodynamically stable agents like etomidate. Pregnancy, avoid tachycardia and volume overload, and go for mitral valvotomy and commissurotomy, as we have discussed in the previous slide. Okay, so these are the goals of the decompensated MS, and this is the most important slide which is needed for you in the ICU. So in the exam, this is the slide that one is looking for, and you need to produce. Coming to our next topic, so the next four topics that we have, it is related to post cardiac surgery care. Okay, these are very interesting topics, and most of the time we don't read up these topics, so better concentrate right now on the slides that we have. So evaluation and management of post cardiac surgery shock, this will be the flow of my topic. Post cardiogenic shock constitutes the most serious clinical expression of the post heart surgery low cardiac output syndrome. It is defined by a decrease in the cardiac output that leads to hypoperfusion and hypotension. That is a cardiac index of less than 2 liter per minute per meter square, SBP of less than 90, pulmonary capillary wedge pressure of more than 16 to 18 millimeter of mercury, and oliguria. In hospital mortality occurs following cardiac surgery in 2.6% of the cases. Now, pathophysiology includes local surgical damage, Ischemic perfusion injury, which happens because of massive calcium entry to the cell with dysregulation of the cellular mechanisms, increase in the free radicals causing oxidative stress, and mitochondrial permeability dysfunction. So, these are the mechanisms by which the ischemic reperfusion injury occurs. And last but not the least, we have the extracorporeal circulation, which itself can cause some amount of microvascular dysfunction. The imbalance between the damaging and the protective mechanisms cause postoperative myocardial stunning, and uh, it maximally causes the secondary cardiogenic shock. So, how will you evaluate? History of the patient, quite similar to any kind of shock history. One needs to ask the prior history, anesthesia, past history, medical history, allergies, preoperative medication, any kind of symptoms. And if the patient has gone on the cardiopulmonary bypass, then one needs to ask regarding it are aortic clamp time and problems and complications, if any, that has happened in the OT. Physical examination, look for signs of bleeding, abdominal examination, peripheral pulses, skin, urine output, all the things that are needed for shock. Basic hemodynamic management has to be done. Go for ECG, echocardiography, chest x-ray to look for further signs of what is the cause of shock. And extended hemodynamic assessment need be done in such cases. For example, pulmonary artery catheter might be an important tool, okay, along with further advanced kind of monitoring, for example transpulmonary hemodilation if present in your setup. So what could be the diagnostic approach in post cardiotomy shock? What is the difficulty is that such patients can present with mixed shock, because there might be a primary cause of shock and there might be a secondary cause of shock. Therefore, available monitoring devices as much as possible with physical examination is needed to narrow down the diagnosis. For example, if the patient has come with a cardiogenic shock, peripheries will be cool, congested, there will be narrow pulse pressure, decreased in the capillary refill time. Hemodynamics need to be monitored and the echo has to be done. Bedside focus is one of the most important tools. We know the false protocol. We know how to identify different types of shock as we have studied yesterday. And uh, so systolic, diastolic valvular dysfunction needs to be found, and whether patient has got a narrow pulse pressure. Vasodilatory shock, on examination, patient will be warm, dry with white pulse pressure. Okay, need to see the capillary refill time. For other hemodynamic mechanics like passive leg raise test, hmm, and patient will present with a white pulse pressure. Obstructive shock, okay, very similar to the cardiogenic shock, but look for other signs. For example, echocardiography, it is one of the most important tools to differentiate between these. There is loss of lung sliding in case of pneumothorax, okay, presence of a lung point. One can find out signs of pulmonary embolism. Any intracavitary obstruction is there. Any localized effusion is there. Last but not the least, we have the hemorrhagic shock, where it will be a narrow pulse pressure with underfilled left ventricle and hyperdynamic systolic function. So post-cardiotomy cardiogenic shock, it is found in 2.4% of the cases in case of an isolated CABG, 3.9% in aortic valve surgery, and 7% in case of a mitral valve surgery. It has a 20% mortality with risk factors like it is more common in case of older age group, female sex, preoperative renal failure, preoperative cardiogenic shock, and pre-existing left ventricular dysfunction. The management is very similar to any heart failure management. There is also something called a secondary cause of a post-cardiotomy cardiogenic shock, where ischemic injury is the most important contributor, and it results from graft related factors, intraoperative ischemic reperfusion injury, any coronary artery injury, or any kind of other acute coronary lesion. And in such cases, atrial arrhythmias are common. Vasodilatory shock, the risk factors include how much is the duration of the cardiopulmonary bypass? Preoperative, whether any AC inhibitor has been used. So probably it might cause further hypotension of the patient. Vasopressor use. Alternative etiologies for these cases include if the patient already is in sepsis, has an adrenal insufficiency, uh, other comorbids like liver failure, pancreatitis, and such the population who are at very high risk of a postoperative sepsis are those who are undergoing surgery for infective endocarditis, or those who are undergoing an orthoptic heart transplant. Hypovolemic and hemorrhagic shock. So basically bleeding post cardiac surgery. We will be discussing in detail in the next further topics. So I'll skip this part. Obstructive shock. We need to see the causes of the obstructive shock, like cardiac tamponade, pulmonary embolism, any pneumothorax is present or not. How will you manage? So correct the mechanical problem first. If there is any bleeding, any tamponade, immediate whether any surgical correction is needed. Optimize preload. Start with a crystalloid infusion, okay? And colloid has been mentioned in the guidelines, but we usually go for crystalloids. Optimize the vascular tone and perfusion pressure. Most commonly used is noradrenaline, even for a cardiac case. Optimize myocardial contractility, just like in case of any failure case, dobutamine, milrinone needs to be used. Any kind of tachybrady arrhythmias needs to be managed accordingly, whether pacing is needed, whether electrolyte correction needs to be done, any kind of antiarrhythmics or electrical cardioversion needs to be seen. Optimize the oxygen delivery and treat the cause. For example, patient is in sepsis. Any SIRS response, whether any shock dose needs to of hydrocortisone needs to be given. Patient needs to be given methylene blue. So all those things has to be seen. These are the entire collection of drugs in the armamentarium that we have, not only for a post cardiotomy shock, for any kind of shock, and these needs to be used. So management principles, our next topic is management principle and diagnostic evaluation in a post cardiac surgery bleeding patient. This will be the flow of my talk. And what is the definition of post cardiotomy bleeding? Basically, the moderate bleeding was defined as between 800 to 1000 per 12 hours. Severe perioperative bleeding was defined between 1000 to 2000 per 12 hours, and massive was more than 2 liters per 12 hours. The Bleeding Academic Research Consortium definition says 2 liters in the chest tube output within 24 hours of CABG. So these are two definitions which have been given. Any one of the definitions you can mention in the exam, and there are various risk scores like will bleed, has blood, and Papworth score, which helps in identifying the at-risk patients. And excessive bleeding in the cardiac surgery increases the risk for re-exploration. And prompt re-exploration for bleeding, it reduces the risk of adverse outcomes. So basically, one needs to be very prompt with the decision if re-exploration is needed. Causes of post cardiac surgery bleed. So there could be surgical causes, there could be medical causes. Surgical causes, if there is a poor hemostasis, any accidental injury, coronary artery graft anastomotic failure. Medical causes of post bypass hemorrhage includes hemodilution, hypothermia because of clotting factor dysfunction, preoperative platelet inhibitor therapy, inadequate reversal of heparin. So these are the causes, or you can divide them into patient related variables, preoperative medications, and procedure related variables. So, how to minimize these operative blood loss? So, how are we going to minimize? So, when a patient has come from a surgery or is going into a surgery, what are the things we need to think of? We can divide it into preoperative, intraoperative, and postoperative measures. First of all, identify the at risk bleeding patients. All right. Correct anemia if need be. So, anemia is one of the risk factors for any kind of cardiac patient. It can further worsen failure, as we have studied yesterday. All right. And then fibrinogen level testing, platelet function testing if the patient is on dual antiplatelets. So, those are needed. Intraoperatively, one needs to maintain the homeostasis, minimize the hemodilution, individualize the heparin protamine titration in 1:1. Normothermia needs to be maintained, prevention of fibrinolysis, use of tranexamic acid, and use of a cell saver. Salvage pump blood via either hemofiltration or cell saver is needed. Post-operatively, point of care tests are needed. If the patient needs any kind of blood products, then one has to be proactive in giving of these blood products. Okay, appropriate blood product uh, has to be given, and one can use point of care testing. Even TEGs are available, ACT is available in the OTs, in all of cardiac OTs. So these needs to be used for point of care testing. Coming, this is a very important slide because I think it gives not only the importance of stopping the antiplatelets prior to coronary bypass surgery, but also for other surgeries, we can use this slide. So basically, if the patient uh, is on aspirin, emergency surgery, proceed for surgery. Urgent or elective surgery, also we continue the aspirin. And if it is a very high risk bleeding case and or patient is refusing transfusion, then there are guidelines to say that you can stop it at least 4 days preoperatively. But nowadays we do not stop, we continue with the aspirin. But if the patient is on dual antiplatelets, what do we do? Emergency surgery, just proceed with the surgery. For P2Y12 inhibitors, what is supposed to be done? For ticagrelol, stop it more than 3 days, clopidogrel more than 5 days, and prasugrel more than 7 days. Continue with the aspirin and consider bridging with cangrelor of the GP2B or GP2B 3A blockers in high risk thromboembolic cases. For elective surgery also, we need to delay this or stop this before the surgery, but continue with the aspirin. So for patients scheduled with the CABG, it is advisable to cease these at least 4 hours before the operation. So for G2P3A blockers, it is advisable to be stopped at least 4 hours before the operation. So that needs to be remembered. Continuing with the anticoagulation. Now, this is also very, very important slide that one needs to understand. So, when do we withhold the anticoagulation in such patients? So, suppose this is the day of surgery. For a low molecular weight heparin, one needs to stop 1 day prior. Okay. But after the surgery, it can be started after 24 hours if indicated. Okay. Coming to the DOACs needs to be stopped at least a minimum of 48 hours before the surgery. I'm telling minimum of 48 hours. And it can be restarted at least, a minimum of uh, 3 days after the surgery. And the low molecular weight heparin, and what I mean to say is that when we start unfractionated heparin and low molecular weight heparin 24 hours after surgery, then it can be bridged with the DOACs at least 3 days after the surgery. Okay. And in case the INR is more than 2 or the INR is more than 2.5, then the low molecular weight heparin needs to be stopped. And later on, you can start off with the vitamin K antagonist. So this is one of the most important slides. And vitamin K antagonist needs to be stopped 5 days prior to the surgery. So this is one of the most important slides. Please just keep this picture in your mind and produce it in the exams. Empiric dosing of heparin is given to achieve an ACT of more than 480 seconds, which is recommended in case of any OT. And heparin resistance needs to be, which is defined as achieving an ACT of less than 400 seconds, even after administration of 300 international unit per kg of heparin. This resistance may necessitate giving a higher heparin dose. All right. So patient might have a risk of having a higher residual heparin post-operatively, and maybe a higher risk of bleeding. So patient blood management, what is the target of hemoglobin? The target of hemoglobin is it is a gray area. While the guidelines say the females, the target should be kept as less than 12. For the males, it should be kept less than 13. And IV supplementation has to be done. We have got various trials in acute myocardial infarction, in case of various cardiac surgery, which suggests that we can keep around 10, because there is no significant difference between keeping it at around 7 8 or around 10. So most of the trials, we based on most of the trials, will keep around 10. Recommendation for the post operative management: in the post operative management, one has to have a low threshold for identification of the bleeding. Check for the tube drainage output. What is the tube drainage output? Any triggers for the reintervention of bleeding is there, whether there is any hemodynamic instability. Prompt correction of the triads, the lethal triad needs to be done. Okay. And VT profile access, LMWH should be considered for the patient, but we need to have a low threshold even for bleeding after that. Detection of hit should be early. So if the patient has a high risk for bleeding, or you are thinking regarding bleeding, immediately get an X-ray done. Quantify the degree of the bleeding, hemodynamic status, coagulation studies, repeat the studies if need be, and obtain a TEE if you're concerned about a tamponade. So management: if there is a bleeding or a tamponade, manage accordingly. check if your chest tubes are patent, control the lethal triad, control the hypertension, agitation, normothermia needs to be maintained, check the point of care testing, give ionized calcium, protamine is to be given 25 milligram IV for 2 doses if there is an elevated PTT, or infusion can be given over 6 hours. Then use PEEP with caution, give off the blood products. So basically protamine is given, platelet in case there is any dysfunction, fresh frozen plasma if the INR is more than 1.5, or you can also use a PCC. And for fibrinogen, low fibrinogen, one can go for a cryoprecipitate or a fibrinogen concentrate. Also, recombinant factor 7A has been used as an off-label use for a patient with uncontrollable coagulopathy, with a dose being 90 gram per kg, followed by a second dose after 2 hours. And the half-life is around 2.9 hours. So general guidelines for re-exploration is what? More than 400 ml per hour for 1 hour, more than 300 ml per hour for 2 to 3 hours, or more than 200 ml per hour for 4 hours. See this, if the bleed is more than this, okay, then re-exploration of the patient is required. And it is found that early exploration reduces the adverse outcomes by minimizing the use of multiple transfusion, avoiding averting hemodynamic instability and low cardiac output syndrome, which can lead to multi-organ failure. It also reduces the risk of tamponade and cardiac arrest events and lowers the risk of wound complications. So the multidisciplinary approach, this is the star slide that you have to remember. The prior admission, preoperatively, how are you going to manage? Intraoperatively, what is the minimal things you can do to decrease or minimize the postoperative bleed? However, if there is a bleed, what is the algorithm that one has to manage? So this is the guideline 2024 EACTS guideline on the management. So cardiac arrest following cardiac surgery. This is one of the questions that is anticipated. It will come in one of the coming years. Okay, CALS protocol. So please listen. What is the difference with the our normal algorithm for the cardiac arrest? So how is this post cardiac surgery cardiac arrest different from that of the normal the regular algorithm that we study? So first, it is always witnessed. The cardiac arrest occurs after 0.7 to 2.9% of the cardiac surgery cases. The survival chances in such cases is around 80%. Okay, it is rarely sudden. You will have some signs or symptoms 12 hours prior to, or just immediately after the OT. You will have some signs that needs to be recognized. Either the lactates are going to be high, the blood pressure will not be settled, there will be increased output, worsening oxygenation, or some rhythm abnormalities. There's usually no delay in the diagnosis because such patients are maximally monitored, and these patients are in the hospital. So, early management is the key in such cases. And if the patient has arrested in front of you, obviously, the patient management will be early. It is usually due to an early reversible cause. The most common causes are VF, cardiac tamponade, or any major bleeding. Reopening the chest is the final common pathway. Of the 4H and 4T, which are applicable in all the amenable cardiac arrest cases in a post cardiac surgery, okay, for other cases, you might go for shock. For other cases, you might, give the drugs. But in a post cardiac surgery, cardiac arrest, the one line that you have to remember is reopening the chest is the final common pathway. Okay. So, assignment of this goal is to provide the definitive treatment as early as possible. Whether you open the chest or you defibrillate, timely desternostomy is an important goal, as CPR is ineffective in such cases. Okay. So, manage the main management first. Even if you give CPR, the ideally such patients need to be opened up and call a surgical emergency. This is one of the cases where it is a surgical emergency, and get the surgeons in the OT ASAP. Okay, 6 roles which are assigned. So what are one person has to be there for the external cardiac massage, one person has to be there, that means for the CPR. Airway breathing needs to be managed, so one person needs to manage the defibrillation. There has to be a team leader like any other cardiac arrest protocol or ACLS protocol. Drugs and syringes, one person can manage, and there has to be an ICU coordinator. So this is another important role which is different from that of the other cardiac arrest cases, where the ICU coordinator has to run and call the OT and activate along with the surgeons as early as possible. So coming to the cardiac arrest protocol. So first is assess the rhythm. What is your rhythm? We have whether you have a ventricular fibrillation or a tachycardia, okay? Whether you have an asystole or a bradycardia or a pulseless electrical activity. So if we have a VF or a tachycardia, all right, go with 3 attempts of DC shock. This is another difference that you have from the previous, the other ACLS protocol. 3 attempts of DC shock, okay, for asystole. And for the bradycardia, symptomatic bradycardia, go with the pacing, the pacing as early as possible, and start basic life support. So before you start anything else, CPR, everything else, please make sure that if this is the protocol and the cardiac arrest is because of a post cardiotomy case, this is what has to be done. Start basic life support, go with the drugs. For a VF or tachycardia, the drug of choice is not giving adrenaline. You have to give an amiodarone 300 milligram via the central line. For an asystole or a bradycardia, give atropine 3 milligram or consider external pacing. And if paced, turn off the pacing to exclude any underlying VF. Okay, this also needs to be checked.
क्या
And
बात है।
hello. Okay. Prepare
मैं
for
क्या
an
हूँ, जो आप
emergency.
लाओगे सब खा सकते हैं।
Prepare
नहीं
for an
करना है कंसोलिडेशन।
hello. Okay. Prepare for an emergency resternotomy. Kindly mute everyone. Prepare for an emergency resternotomy. Okay. Continue the CPR with a single DC shock every 2 minutes until the resternotomy happens. Continue TPR until the resternotomy. Continue CPR until the resternotomy. So what one has to remember, that resternotomy is the final common pathway for this kind of arrest. Okay. And manage the ventilation. Put on 100% oxygen. Switch off the PEEP. Bag and valve ventilation has to be done. Check if there is any pneumothorax or a hemothorax. If there is any tension pneumothorax suspected, immediately place the large bore cannula. Do not give adrenaline unless a senior doctor advises. So this is an important difference with the other slides, the other ACLS protocol. If an IABP is in place, change to a pressure trigger. Do not delay basic life support for defibrillation or pacing for more than a minute. Suppose things are not available, then go for a basic life support immediately. Okay. So defibrillation, this is a class 2A level B. Pulseless ventricular tachycardia, ventricular fibrillation, delay the external cardiac massage. Do not give a CPR unless it is more than a minute. Give shock. Spacing is required as early as possible in case it is available. Resternotomy, inability to obtain a systolic blood pressure more than 60 millimeter of mercury on the arterial trace. Please go for an emergency resternotomy. Activate the OT. Infusions in established cardiac arrest, all the infusions need to be stopped. Okay, automated external defibrillator should not be used in cardiac surgical patients. If a manual defibrillator is available, and it should not, as I said, AED should not be available. It in fact causes more harm rather than benefit. Epicardial pacing for asystole or severe bradycardia, connect the epicardial pacing wires set to DDD mode at 80 to 100 beats per minute. That is a class 1 recommendation. For atropine, in other cases, it is not recommended. Asystole, extreme bradycardia, initially do not do atropine. Okay, there is no benefit. First, do pacing. So, pacing is what has to be done. Then later on, go for other drugs. And emergency restonotomy, we have been mentioning it again and again. So, the word that you need to remember is maintain a if the blood pressure is less than 60 millimeter of mercury, then go for the emergency resternotomy within 5 minutes, and even if resternotomy, if you have a center where ECMO is available, then go for a rapid initiation of ECMO, which is an alternative. uh, Okay, internal versus external cardiac massage. In fact, internal cardiac massage is said to be more productive than that of an external cardiac massage in such patients. Okay, and in fact, internal defibrillation can also be given directly to the heart. 20 joule shocks can be performed, and 5 joules in case of a patient with bypass. So the critical points are what? Call the code, notify the cardiothoracic surgeon, connect to the defibrillator, emergency pacing button, give stack shocks in case of VT and VF, aim for a systolic blood pressure of more than 60 millimeter of mercury, All right. If defibrillator is not available or pacing is not available more than a minute, then go for the CPR. IABP change to pressure trigger. Drugs, amiodarone is given, but we do not give atropine, adrenaline in such cases. And emergency resternotomy to be done like arranged within 5 minutes, or alternative being ECMO. So this is the guideline that I have taken it from. I hope if this question comes, nobody is going to mess it up, because it has been very, the last slide is what you need to produce. Coming to the concept of defibrillation, this will be the flow of my talk. All right, there is a short history that one can go through if they are interested. So, defibrillation is a non synchronized delivery of a shock randomly during the cardiac cycle. Most of them are energy based, and the amount of energy that uh, that is given in the myocardium is dependent on the selected voltage and the transthoracic impedance, which varies in different patients. Okay, the application is giving the electrical current across the heart to convert the VF or the VT rhythm into the sinus rhythm. Now, there are two types. One is the impedance based defibrillator, the other is the current based defibrillation. The impedance base allows the selection of transthoracic current based upon the transthoracic impedance, and the current based is independent of transthoracic impedance and body weight and gives a fixed dose of current. Now, what is the principle? The principle is basically at cellular level, there is alteration in the transmembrane potential. The delivered current flows around through the myocardial cells and causes alteration in the transmembrane potential. And there are two mechanisms at the organ level. One is the critical mass hypothesis, and the other is the upper limit of the vulnerability hypothesis. Now, critical mass hypothesis is DC shock produces a current in density which depolarizes a critical mass of the myocardium, thereby leaving insufficient myocardium to maintain the reentrant tachycardia and prevent the reinitiation. So basically, there will be one part of the myocardium which will be depolarized, another part of the myocardium which will be hyperpolarized, and in between there will be a small area of the myocardium which is the critical mass of the myocardium, which uh, where the current density is produced. So the critical point is formed on the boundary between the depolarized and the hyperpolarized region, and the hyperpolarization can de-excite the tissue that was depolarized just before the shock, thus restoring the excitability of the myocardial in that region. Okay, and the next one is the upper limit of vulnerability hypothesis. So basically, what happens is when you have any kind of uh, uh, these VF or the VT, so basically, this happens between a threshold of the shock strength. We have a lowest threshold and it can extend up to a highest threshold of the shock strength. So, to successfully defibrillate the patient, one needs to go above the shock strength, should be above the strength of whatever the VF or the upper limit of the VF strength is. Okay, I hope you are able to understand. So, to successfully defibrillate, the shock strength must be greater than the largest shock that initiates the fibrillation. So, this is called the upper limit, and this is the second hypothesis that uh, is the principle of the defibrillation. What could be the factors that affect the defibrillation? So basically, we have got the electrodes. It can be enteroposterior. Enterolateral. It can be enteroposterior, or it can be double sequential external defibrillation, where you have the enteroposterior and the enterolateral leads which are stacked together, and they give a continuous shocks from the two defibrillators. It is mainly used in case of refractory ventricular fibrillation, or in case of an even electrical storm. Pad size can affect the defibrillation. It decreases the resistance, increases the current flow, and causes less myocardial necrosis. ANSCO guidelines suggest more than 8 centimeter square size pads. Okay, optimal electrode size is also needed. Approximately, it is said to be around 12.8 centimeter. Handheld uh, paddle electrodes are more effective than the self-adhesive patch electrodes, because the pressure applied will be uniform and it allows the electrode to be closer to the heart. Then monophasic versus biphasic. I think everyone knows this by now. Biphasic will defibrillate more effectively compared to and at lower energies compared to that of monophasic waves. Uh, Patient related variables include transthoracic impedance. So we have this around 70 to 80 ohms is normally present, and the effect is determined by multiple factors. For example, the energy level that one has used, electrode to skin interface, inter-electrode distance, electrode pressure, phase of the ventilation, and the blood conductive properties and the conductive properties of the tissues. For example, the composition of the gel itself can result in some kind of impedance and affect the defibrillation of the patient. Type of arrhythmia. Primary ventricular fibrillation will be easier to defibrillate compared to that of any kind of secondary VF, maybe secondary to any heart failure. A monomorphic VT needs a smaller current compared to that of a polymorphic VT and VF. Okay. Duration of the arrhythmia. If the duration of the arrhythmia has already been longer, then the effectiveness gets reduced. If it is a recent onset, then it is more effective compared to that of a late onset. Use of antiarrhythmics can also increase or decrease the defibrillation. Sodium channel blockers increases the energy required for defibrillation, while potassium channel blockers and catecholamines decrease the energy needed. CIED, or the cardiac implantable electronic device. Now, the position of the electrode pads should be such to avoid any contact with the skin overlying the CIED to maximize the efficacy and minimize the damage to the CIED. Circumstances in which the patients may be refractory to the defibrillation: extreme hypothermia, intoxication with volatile solvents, prolonged resuscitation or prolonged hands off downtime, that is arrested but CPR has not started. Chronic amiodarone therapy, it increases the energy requirement in case of shock by about 60%. Phenytoin therapy, it may theoretically increase the resistance of the myocardium. Complications, the DC shocks are more effective and less damaging than the AC. Repeated shocks causes myocardial damage, electrocution of the members of the resuscitation team, that's the need for saying all clear. Biphasic causes less myocardial damage, it can cause burns, and implanted defibrillators or other metals, there might be some impact on these devices. So this is the star slide that one can go through. It has got everything from paddle size and position, the shock dose, sedation, anticoagulation mechanism. All right. In case of an AF, one needs to know when to give the anticoagulation. All right. Less than 48 hours, more than 48 hours. Uh, so for it cardioversion in the AF patient, there is a risk of thromboembolism. So you do not immediately shock the patient. Okay, you wait, give anticoagulant therapy, wait for 3 to 4 weeks, which decreases the embolism. So this is one important point that can be mentioned when you are talking about this. Okay. Coming to our next topic, which is complete heart block and pacemakers. Here I'll be essentially talking about pacemakers. So, pacemakers are the electronic devices which stimulate the heart with electrical impulses to maintain and restore the functional heartbeat. And there are three types. Mainly, you have the permanent ones and the temporary ones. The temporary ones are mainly the portable ones, which can have a pulse generator with exteriorized electrodes for the temporary transvenous pacing, or you can have the battery powered cardioverters for the temporary pacing. Now, all the pacemakers consist of two components. One is a pulse generator, and the other is the electrode or the leads, which can deliver the electrical impulse to the myocardium. It can be single chamber. Okay, so for example, we have one which is in the ventricle. So this is in the ventricle. Then we can have the dual chamber, which uses two leads to stimulate one the atrium and the other the ventricle. We can have a biventricular one, for example, the two leads, one is in each of the ventricles, and even leadless pacemakers are nowadays are available, and these biventricular pacemakers are the one which are the cardiac resynchronization therapy devices. Indications of temporary cardiac pacing. So we have sick sinus syndrome, heart blocks, drug refractory dysrhythmia, and the cardiovascular surgery. So cardiac sick sinus syndrome, if symptomatic sinus arrest or sinus pauses, suppression of the ventricular ectopy resulting from bradycardia, atrial fibrillation, brady syndrome, and symptomatic sinus bradycardia. So these are the indications. Heart block. Type 1 and 2, usually these are not the class 1 indications. Okay. Type 2 symptomatic secondary heart block is actually a class 1 indication. And acute bifascicular or a trifascicular block, complete AV block or cardiac arrest due to a ventricular asystole. Drug refractory dysrhythmia, when there is an overdrive ventricular pacing to suppress or prevent ventricular ectopic activity, or pacing to break the supraventricular tachycardia or atrial flutter, then also it is used, and it can be used post cardiovascular surgery. Coming to our mode selection. Now, before coming to which mode to do, one needs to know what does each of the terminologies mean. So we have the position 1, 2, 3, 4, 5. All right. So for first is the chamber paste. Chamber paste, it comprises of, it can be none, atrium, ventricle, or dual modes. Then we have chamber sensed, none, atrium, ventricular, and dual, where the chamber sensing has happened and response to the sensing. So after the sensing takes place, what is the response to that sensing event? So that is given by the position 3. That is none, triggered, inhibited, and dual. And last is programmability and anti-dysrhythmic functions. So the first three are the most important one, where it is the pace chamber, the sense chamber, and the response to the sensed event. You can remember it as pacers, paced, CE for sensed, and RSS response to the cardiac event. For example, we have DDD. So pacing to both the atrium and the ventricle is happening here. Sensing to both the atrium and the ventricle is happening here. It can either inhibit or trigger the pacing. So DDD. Similarly, we have the VVI. The most common modes are the VVI and the DDD. And most pacemakers will respond to a magnet exposure by becoming asynchronous. All right. So, this is an important point that one needs to remember. The four basic concepts of pacemaker functioning are connection, output, capture, and sensitivity. So, where the connection is happening, usually, so we have this. I believe everyone has seen a temporary pacemaker in their ICUs, and we have the buttons, the various buttons which manage the rate, the voltage, and the sensitivity, and it can be seen, whatever you are changing can be seen in the monitor of the temporary pacemaker. One also has the connections. So we have the atrial connector here, the ventricular connector here, and then we have the battery connector somewhere below. Okay, so these are the connections that are seen in case of a temporary pacemaker. Other terminologies include what is rate, the pacing rate in beats per minute. Usually it is set as a backup rate. The output of the pacemaker, it is the current which it produces as a brief pulse. To prevent loss of capture, the output is set 1 to 1.5 times higher than the identified pacing threshold. Sensitivity of the pacemaker electrode is the minimum voltage that is required to detect the P wave or the as a P wave or an R wave. And the normal settings is around zero point 0.4 to 10 millivolt for the atria and zero point 0.8 to 2 millivolt for the ventricles. What is a capture? It is the effective stimulation of the cardiac depolarization by the pacemaker. If the atrium is paced, then the spike will appear before the P wave. If the ventricle is paced, the spike will appear before the QRS complex. Capture threshold is what? It is the minimum amount of current which is required to initially depolarize the chamber. So, capture and capture threshold. So, what are the problems that one faces while using these pacemakers? Here we are talking mainly about temporary pacemakers because that is something that we commonly use in our ICU. So, what are the problems that we face? We have the capture failure, and we have also the problem of detecting the intracardiac signals, which is the sensing problem that could be undersensing or oversensing. And sometimes the pacemaker itself can pseudo malfunction, which could be rate related, atrioventricular related, okay, or even the model related. So, factors which influence the capture and the sensing, it could be fluid status changes, pericardial effusion, electrolytes, medications, battery failure, uh, low generator voltage or high pulse generator amperage, development of endothelial sheaths, any kind of dislodgement, disconnection, or the fracture. So, these things will cause any kind of output failure as well. Capture failure. So the main problem, you can remember the capture failure as bed fast. What is bed fast? Battery failure, disconnection at any point, fracture of the wires and cables, settings which are inadequate, or any threshold change which can lead to a low output state. Okay, and for we have one of the examples here. For example, ideally after a pace you have this spike, right? So after a spike, ideally we should have had, this is a ventricular pacing, and ideally after a spike we should like dual chamber pacing. We have the atrium that is the pacer before the uh, uh, atrial rhythm, and then this is the ventricular. So before that, ideally, the pacer should be there, but here there is a distance. So here there is a failure to capture this, and this is a failure to capture the ventricular spike. Okay. So the pacing threshold is the minimum energy that is required, which constantly triggers or depolarizes the pace chamber. This we have studied in the previous slide. And now we need to understand what is sensing. Okay, so under sensing occurs when the pacemaker fails to detect the spontaneous myocardial depolarization, and it which results in asynchronous pacing. So atrial and ventricular pacing spikes arise regardless of the P waves or the QRS complex. Ideally, what happens? You have the spikes, and which is followed by the wave, right? But suppose the spike is happening irrespective of the waves. In this case, there is a ventricular undersensing. So the spike should ideally have been here, correct? And then we should have the ventricular this waveform, but it has happened after. So this is ventricular undersensing that is happening, and the main causes could be improper sensing threshold, any kind of insufficient signal, or fibrosis fracture, or an electrolyte abnormality as well. Coming to oversensing. So oversensing, what happens is the pacemaker itself, it encounters some abnormal electrical signals, because of which it will not be able to give the proper pacer spikes, and thus the sensing will also not happen. So ventricular oversensing, example being here, what is happening here is, after the third sinus, ideally there should have been a pace, and then the sensing should have happened, right? So here, the ventricle would have detected some electrical signals by the patient themselves, as a result of which the pacing spike is absent, and thus this is not followed by a waveform. So there is inappropriate inhibition of the pacing, and an asystolic pause that has happened. So failure to capture, there is the pacemaker stimulation do not result in myocardial activation, and failure to pace, that is, the pacemaker does not stimulate as expected. So how are we going to do this pacemaker setup? Locate the generator, see if the battery is working or not. Each wire needs identify each wire which has to go in the atrium and which has to go in the ventricle. Epicardial ventricular wires exit on the left side of the chest. Atrial wires from the right side of the from the right side. Identify for the positive and the negative leads. Okay, attach the wires at the appropriate site. See, turn the pulse generator on, and whatever rate has to be set. Usually, for a surgical patient, it is 90 to 110. For medical patient, 70 to 90. For a cardiac arrest patient or cardiac patient, 80 beats per minute. Okay. Then set the milliamperage. In non-urgent situations, 10 milliampere. In emergent situations, 15 to 20 milliampere. It is normally kept. And see for the sensitivity. Usually, adult guidelines say start at 2 to 5 millivolt. Okay. If failure to sense occurs, then turn down the sensitivity. If the pacer is sensing beats which are not usually present, then turn the sensitivity up. So this is an important point that one needs to know to prevent undersensing and oversensing. All right, see for the patient responses and keep continuously securing the wires and all the connections. Complications, this CRT I'm not going to discuss. We have discussed the guidelines yesterday. Complications, implantation related and delayed. There could be hematoma, infection, pneumothorax, hemothorax. There could be fracture, dislodgement, pacemaker induced cardiomyopathy, thrombosis, pacemaker mediated tachycardia, and all. So this is the star slide. If you go through this one slide, I think you will, whatever I have covered is present in this one slide. Okay. Coming to electrical storm, this is another very important small topic which might come. So uh, what is an electrical storm? Basically, that you have three or more episodes of the ventricular fibrillation or ICD shocks which are happening within 24 hours, and that need intervention. Generally, it is associated with poor outcomes. The triggers being, it could be drugs, it could be electrolyte abnormality, any kind of heart failure, ischemia, thyrotoxicosis, QT prolongation. These are the triggers for the electrical storm. Pathophysiologically, there is a neurohormonal balance with these predisposing condition. There is increase in the action potential depolarization, calcium overload leading to altered phosphorylation of the calcium handling proteins, and thus it can also lead to structural remodeling, re-entry leading to VF and defibrillation. Clinical presentation, they can span from relatively minor symptoms in hemodynamically stable patients like palpitations, syncope, or it can also lead to cardiac arrest. ECG changes might, you might not likely capture it on a standard 12 lead ECG, but it might require continuous monitoring with a surface ECG or continuous ambulatory telemetry or intracardiac electrograms as recorded by an ICD. All right. These are the percentages of the electrical problems where we find electrical storm, uh, and the maximum being in monomorphic VT. Diagnosis, as I said, your typical ECG might not give, and a telemetry monitoring or intracardiac electrocardiograms from a patient's ICD might be needed. Okay, differentials in a patient without the ICD, usually any kind of QRS complex cause might be a DD for this. And in patients with ICD, one needs to know that apart from the usual wide complex tachycardia, there could also be possible ICD malfunction. Treatment, hemodynamically unstable patient, go for the normal ACLS protocol for a VT or a VF or any kind of tachyarrhythmias. Okay, sorry. And for hemodynamically stable patient, you treat it with drug therapy, that is IV amiodarone is the drug of choice, which is one can also go for a beta oral propanolol. Oral propanolol is what is said, 40 mg every 6 hours for the first 48 hours. Okay, if there is a torsitis point is happening, then magnesium 1 to 2 gram IV is given. And in a patient with ICD, go for an ICD interrogation and assessment of the programming. Coronary revascularization are needed in case of an MI case. Subsequent management may involve catheter ablation, maintenance of the antiarrhythmic therapies, and condition-specific therapies. For example, pacing might be needed, heart failure therapies, any kind of revascularization, correction of electrolytes, removal of any offending drugs, okay, and any inciting factor that needs to be removed should be removed. Refractory cases are managed by thoracic epidural anesthesia, IABP, or any temporary assist device. Stellate ganglion block has been said to be one of the temporizing measures, along with terminal sympathectomy uh, via surgical cardiac sympathetic denervation or orthoptic heart transplant may also be needed in case of eligible non-responders. Renal artery denervation and stereotactic body radiation therapy have also been mentioned as potential management for refractory cases. So this is the one slide that you should know. More than 3 sustained VTVF in 24 hours, more than 3 ICD therapies in 24 hours, or recurrent VT within 5 minutes, the substrates, the triggers, the autonomic dysregulation, and the management while managing them chronically. So this is one chart, the star slide that we need to follow. Coming to our next topic, which is the long QT syndrome, another emerging cardiology topic, which had come actually last time as a long question. And we were wondering actually what to write. But at the end of the day, you can somehow gauge. But right now, just go through this slide very carefully. It is primarily diagnosed in a 12, you have to see the 12 lead ECG. Okay. And see for the normal QT interval, which is will starts with the beginning of the Q wave to the end of the T wave. So this is your QT interval. And a prolonged QT is said when the in case of more than 450 milliseconds in case of men and more than 470 in case of a female. And QT interval, one needs to understand how to what the formula is. We have the Bezet formula, we have the Fredericia formula. Bezet's formula is normally used, which is QT divided by the RR interval. And and then we have the risk factors for QT prolongation. What could be the risk factors? The cardiac factors: congenital long QT syndrome, history of QT prolongation, I'm sorry, bradycardia, ischemic heart disease, myocarditis, infarction, LVH. Medical conditions can include any kind of stress, starvation, hepatic or renal disease. In case of female sex, medication related and even metabolic, that is, dyselectrolytemia might also cause a QTC prolongation. Now, what is the pathophysiology of this prolonged QT? When we have the normal sodium potassium pump, there is depolarization which happens because of net influx of the sodium, and the repolarization which happens because of net efflux of the potassium ions. So, in the pathophysiology involves mainly this. most of the time, I'm saying most of the time, not every time, but most of the time, it involves the potassium channels. Okay, there are drugs which block the potassium channels, producing a repolarizing current, which is termed as delayed rectifier current, and it results in a longer action potential, resulting in a delayed QT interval. Coming to the congenital causes of the long QT syndrome, so we have various causes. One needs to remember, this might be a busy slide, but what you need to remember is just this. Okay, this and probably this, the protein and this. So the ECG morphology, you have the LQT1, long QT2, and long QT3. Long QT1 comes with a broad T wave. Long QT2, it comes with a bifid T wave. Okay, bifid T wave, and long QT3, it comes with a late T wave. Usually, what is the pathophysiology? The protein blocked here is, in case of type 1, the gene involved is KCNQ1, and the protein involved is a it basically, the potassium channel is what is the current that is involved. In case of type 2, we have the the potassium channel again. But in case of type 3, it is very similar to the Brugada, the sodium, the high sodium channel is involved. Okay. And the trigger for the long QT1 is exertion, fright, and swimming. For the long QT2 is auditory, and the long QT3, even at sleep and rest, they can develop a long QT3 syndrome. Then QT1 is mainly long QT1 is in case of males. The other two are in case of females. And the onset of arrhythmias for one type is non-pause dependent. Pause dependent in case of type 2, and type 3 can happen even at lower rates. And beta blockers are essentially the treatment for all three of them. A sodium channel blocker may be required in case of type 3. Other causes of long QT syndromes are Romanov-Ward syndrome, Jelvin-Lenz, Nielsen syndrome, Anderson-Tawil syndrome, and Timothy syndrome. What are the medications which are associated? We can have antibiotics like erythromycin, clarithromycin, ampicillin, cotrimoxazole, antimalarials, antiarrhythmics, quinidine, disopramide, procanide, sotalol, amiodarone, bretylium. All these can cause. And other causes are amantadine, cyclosporin, hydroxyzin, methadone, nicardipine, tamoxifen. So there are a lot of drugs which are involved in case of a prolonged QT. And how do we diagnose, or how do we find out there is a probability of a long QT? So the probability score is called the Schwartz score, and the score of more than equal to 3.5 indicates a high probability. It involves the electrocardiographic findings, clinical history, and the family history of the patient. Clinical presentation. So first, get a proper medical family history with a 12 lead ECG, an exercise ECG, and an imaging of the patient. Go for other tests also, like electrolyte abnormalities, any kind of metabolic diseases or structural diseases which might be present in the patient. Manual confirmation of QTC and corrected QTC is required. Calculate the long QT risk score, that is the Schwartz score. All right. It could be less than equal to 1, it could be 1.5 to 3. If it is more than equal to 3, then the probability is quite high. And if the QTC is more than 500, then on repeated ECGs, then there is no need for further testing. That is a probability of a high a long QT syndrome. Stop the medications after the weighing the risk and benefit analysis. ECG is needed. Follow up after 8 to 12 hours. Monitor the electrolytes of the patient. Okay. And consider for a cardiology referral. A QTC of greater than 500 is associated with a twofold or a threefold higher risk of a torsitis de pointis. All right. So, what is the treatment like? The treatment, as we have said, any kind of QTC that presents, one needs to go for a beta blocker. If the patient has come in a cardiac arrest, ICDs might be needed. Okay. And then one might need even the left cardiac sympathetic denervation might be required in such cases. Additional pharmacological therapy of blockers of late sodium invert current, that is mexiletine, flecainide, and ranolazine might be needed. And a newer drug which is called as lumacaftor has also been implicated for this condition. So this is your star slide. We need to know the causes. First of all, what it is, what is the presentation, what are the genes involved, what are the acquired drugs involved, what is the pathophysiology, the diagnosis, and the risk factors with the management. First line will always be beta blockers, and the high risk patients which are not responsive to the first line go for an ICD or a cardiac sympathetic denervation surgery. VA ECMO. So now we come to the range of what is called as VA ECMO, and this will be the flow of my slides. VA ECMO is a form of extracorporeal life support. It is a temporary support of patients with acute on chronic cardiac or circulatory failure. And it comprises of a drainage cannula. The circuit comprises of a drainage cannula that removes blood from the right atrium or the large central vein, and it is oxygenated and then reinfused into a major artery. So basically, VV has venous cannulation only. VA has got both the cannulations. VA is mainly for the pulmonary flow. It maintains the pulmonary blood flow. VA ECMO decreases the pulmonary arterial pressure. VV ECMO does not assist systemic circulation. VA ECMO cardiac support, it assists in the systemic circulation. VV ECMO, it is not used in case of right ventricular failure. VA is used. Perfusion rate requirement is quite high. Perfusion rate requirement is low. And lower PaO2 is achieved. A higher PaO2 is achieved. ECMO circuit connection is in series in case of VV ECMO, a very important point. And ECMO connection circuit is in parallel in case of a VA ECMO. There are fewer complications. I wouldn't say fewer, but what I'll say is there are certain VA ECMO specific complications which we'll be studying. So, this is the image that depicts the circuitry of the VA ECMO, where the blood is drained from the venous side, and then it passes through an oxygenator and a blender, and then the oxygenated blood is then carried and it is pumped back into a major artery. It can be of two types. The cannula can be of two types. One is a peripheral cannula, the other is a central cannula. The peripheral cannula drainage is from the right atrium or vena cava, and infusion is into any one of the peripheral vessels. But central cannula directly drains from the right atrium or the vena cava, and the direct infusion is into the ascending aorta. This is preferred post cardiotomy, as cannulas used for CPB can directly be transferred into the ECMO circuit. Indications: any indication for a refractory cardiogenic shock. Okay, it could be acute MI, decompensated heart failure, post cardiac transplant allograft surgery, any kind of arrhythmias, drug intoxication, myocarditis, peripartum cardiomyopathy, stress cardiomyopathy, cardiogenic shock following the resuscitated cardiac arrest. We have studied in the previous slide, post cardiotomy shock, any kind of bridge to transplant, sudden cardiac arrest. uh, well, ECPR is very common, acute decompensated pulmonary vascular disease, and there are other indications as well. Contraindications. Well, you will not find like contraindications to ECMO. However, uh, what is not favorable? Unrecoverable heart, when there is a disseminated malignancy, known severe brain injury, unwitnessed cardiac arrest, prolonged CPR, unrepaired aortic dissection, severe aortic regurgitation, okay, any compliance issues, any peripheral vascular disease. In those cases, it is a contraindication. Coming to the hemodynamic aspect. Now, the hemodynamic aspect, this is one of the schematic diagrams which show that the you are pumping the venous blood. It goes into the oxygenator, it goes into the aorta. So what it does is it goes into the systemic circulation. So what it does is it increases the left ventricular outload and the afterload and the wall stress, and increases the left ventricular pressure. However, it also increases the mean arterial pressure and the end organ pressure. So perfusion is increased. The centrifugal pump delivers the retrograde flow into the aorta, and the map and the oxygen delivery is improved. The preload decreases, the venous drainage reduces the RA and the LV filling, improving the systemic perfusion. The afterload increases, it raises the LV afterload. Sometimes the aortic valve might not open. This is one of the things that can lead to an LV distension or a pulmonary edema. At the end of the day, it is used to reduce the myocardial work and provide hemodynamic and respiratory support. And as I have said, it works in parallel, unlike that of the VV pump. cannulation. So high flows portable cannulas are used. Peripheral cannulation is more common, and the cannula size is around 15 to 17 French of arterial cannula, which is used. It is inserted after an IV anticoagulation of 50 to 100 units per kg. Central cannula cannulation may be done for a severe peripheral vascular disease, but ideally we avoid. Initial settings and titration. So the pump speed is to achieve an extracorporeal blood flow of 3 to 4 liter per minute, and a sweep flow range of 1 to 10 liter per minute, with initial setting starting at a lower end of the range, and obviously 100% fraction of delivered oxygen uh, of 1. Typically, it is not titrated during VA ECMO. We keep it around 1. Respiratory parameters: FiO2 of less than zero point 0.7, PIP of less than 35. These are the respiratory parameters, thresholds that we need to maintain: PEEP of 15, respiratory rate of less than 10. Uh, the pre-membrane oxygen needs to be checked, and it has to be less than the critical threshold. If it is less than the critical threshold, watch for the hypoxemia, perfusion of the right arm if there is a peripheral cannulation. Monitoring has to be done for the cardiac output, pulsatility, ECMO flow, gas exchange, distal limb perfusion. Look for arrhythmias, any lack of pulsatility, and the low flow. Okay. Then blood flow and pressures. So flow 2.1 to 2.4 liter per minute per meter square. Initially avoid less than basically less than 2, because there could be a risk of clot. Pre-membrane pressures are maintained less than 300 millimeter of mercury. Replace the oxygenator if it is more than 150. And temperature, maintain normothermia. Get a daily basic examination workup like electrolytes, CBC, X-ray, and the KFT markers, along with plasma-free hemoglobin and D dimers. Blood cultures can be done thrice a week. ACT targets around 140 to 160, with APTT targets of 45 to 55 seconds. Complications: like any other ECMO complication, we have got the neurologic complication. We could have seizures, intracranial bleeding because of so much of anticoagulation is going on. Hematologic, again, hemorrhage, hemolysis. Patient can come with a DIC. They can develop a hit. Retroperitoneal hematoma, pulmonary, same hemorrhage, embolism, edema, device related issues, cannula related, circuit related issues could be present. Cardiac arrhythmias can happen: cardiac perforation, tamponade, ventricular distension, thrombosis, infection, because at the cannula insertion site can happen, and renal acute kidney injury can patient can also present with. So this is a general ECMO complication. So now we discuss with the V ECMO specific complications. What are the V ECMO specific complications? Mechanism being of LV distension is what? So, as we have studied that from the right side, the blood flows and then it blends with the oxygenator and comes to the aorta. So, there is a persistent LV preload, okay, and a retrograde flow from the outflow cannula, which causes an increased afterload, right? So these together can result in an increase in the left ventricular end diastolic pressure, leading to uh, uh, backflow and a higher pressure, the left atrial pressure. All right. Apart from that, there could also be reduced or absent aortic valve opening, which can due to increased afterload and reduced left ventricle. So these together can result in an LV distension, and the patient can present with a pulmonary hemorrhage, a pulmonary edema, or even a thrombus for that matter. So, uh, how do you diagnose it? To diagnose it, an ECG within 2 hours has to be obtained after the patient goes on the ECMO. And if the pulse pressure is less than 10 millimeter of mercury despite the inotropes, or there is a pulmonary edema on chest X-ray despite a high PEEP, then we think of an LV distension. Okay, so we decrease the flows, keep the patient on vasodilators, inotropes, diuretics, or dialysis might be needed for the patient. Apart from that, any LV unloading strategies, for example, IABP, any kind of mechanical circulatory devices, balloon atrial septostomy, atrial transseptal cannulation, percutaneous LV vent, LV surgical vent, or pulmonary artery vent. So these are the invasive approaches that we have for the LV unloading strategies. So LV distension, go for a non-invasive approach or an invasive approach. Next, we have the differential hypoxia. This is the second VA specific complication, ECMO specific complication. So, what happens here is, so we have no cardiac function, all right, and the regular deoxygenated blood is flowing and goes into the blender, and then we have the oxygenated blood coming back. As the patient is having recovery of the cardiac function, so what is happening here? When we have the recovery of the water, the function of the heart, we have the heart as usual the- will start pumping, so the deoxygenated blood will go towards basically the left side of the heart, right? And then there is a retrograde flow which is coming from the ECMO, right, which is the oxygenated blood. So we have a mixing which is happening, which is called the watershed area, which happens in the arch of aorta, or it can also happen depending on which rate of cardiac recovery is happening in the patient. So this mixing results in what is called as the north south or the Harlequin phenomena, where the patient will have a cerebral hypoxemia, but the blood flow in the other areas of the body will be okay. All right. So, diagnosis is usually the saturation and the PaO2 in the right upper extremity is lower than that of the lower extremities, and infrared spectroscopy can help reveal this regional oxygen saturation in the brain. Patient might have ventricular arrhythmias. The venous drainage oxygen saturation will be unusually high, all right, and there is increased pulsatility in the arterial tracing. So what are the measures to reduce it? Decrease in the native or the impella, like the cardiac output needs to be uh, maintained and reduced, increase in the VA ECMO flow, ventilation optimization, and increase in the FiO2. The definitive or the long term measure would be to convert this VA ECMO into what is called as a VAV ECMO. Okay. Another cannula, a three-way cannula is added to the patient. Okay. So this is a VAV ECMO. Venous drainage cannula in the SVC, central cannulation, uh, getting a reconfiguration with grafted subclavian artery, all right, and conversion of the patient to a VV ECMO. So basically, the blood should not flow completely here. Once the recovery has happened, you gradually change to a VAV ECMO or a VV ECMO in such cases. Another VA ECMO specific complication is a distal limb ischemia. So, usually it happens when the patient is hemodynamically unstable or is on a high vasopressor state where there is a low flow state, or a larger cannula is used in case of younger patients, female gender, any thromboembolic events that has happened, when there are additional risk factors that are present, or patient has perforation or rupture of the common femoral artery, all right, or there is a venous stasis, so or a distal artery compression. So in such cases this particular entity happens, which is the limb ischemia. And how are we going to treat it? So basically there is no distal perfusion that is happening, all right. So ideally you use a smaller cannula to prevent this. uh, uh, a physical examination needs to be done to monitor the perfusion in the limbs. Okay. And the current standard is introduction of a distal perfusion cannula. So basically we have this cannula, that is the cannula which is going into the artery. It is connected to a distal perfusion cannula which can be connected to a the superficial uh, 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 the femoral artery, or sometimes even the profunda femoris artery. Okay. So this can be connected, and then go for monitoring of the limb perfusion with Doppler and near infrared spectroscopy. So bidirectional cannulas can also be used, and there are other novel cannulas which have been designed which can prevent this complication. But limb perfusion monitoring with duplex monitoring is very important in such cases. So VA ECMO cardiogenic shock, we basically, you see, how do we do the weaning? So weaning is done when the arterial pressure, pulse pressure is more than 10 millimeter of mercury. Patient is not having a pulmonary edema. The end organ functions are maintaining. Okay. Then you wean the patient of vasoactive medications, evaluate for the ventricular function, evaluate for the end organ recovery like creatinine, LFTs, all these things. If the patient has a low dose support and the ejection fraction is more than 30%, the mean arterial pressure is more than 60 at a flow of 1 to 1.5 liter per minute, Then you can gradually go for a weaning trial after seeing after seeing the therapeutic APTT and ACT levels. Clamp the ECMO circuit for 3 to 5 minutes and then go for a weaning trial. So weaning trial is successful if the cardiac index is more than 2.2, LVOT VTI is more than 0.15, a map of more than 60, and CVP of less than 18. All right. If it fails, then one has to go either for a transplant or try other devices that like the left ventricular assist device might be needed, or go for a bridge to palliation, basically go for a palliative care. So this is the end of my discussion on cardiac. I know there are a lot of topics which probably we might not have covered, but then this is the basic of whatever we could cover in cardiology. You can write down the topics and we will try to send you articles or recorded versions of our presentations. All right. So, from the heart, now we switch to a completely different topic, which is statistics. Okay. We have to have a reality check on statistics. Unfortunately, I find it very boring, but then this has to be studied because in your first paper, at least 20% of the questions will come from statistics. So, a couple of topics we will discuss here: the forest and the funnel plot. Uh, so, this was one of the questions which had come last year. And what is a forest plot? Forest plot is a graphical tool that visualizes the result of multiple scientific studies on the same topic. The key components are point estimate, the estimated result for a single study. Usually, it is shown as a square, and the size of the square will be proportional to the study's weight or the sample size. Larger studies will have larger squares, and narrower confidence interval. Confidence interval, it is depicted as a horizontal line through the square, which depicts a range, and the true result of the study lies within that range. Overall pooled estimate, the combined result from all the studies, is depicted as a diamond below, and if the horizontal tips of the diamond cross the vertical line, then the result is not statistically significant. Line of no effect is a vertical line in between, which has no difference or impact. And last but not the least, the heterogeneity of the studies are depicted by I square. If I square is more than 50%, it means the studies are inconsistent due to the reason or other than chance. So when you have these type of questions in exam, just make sure you give examples. Okay. So forest plot, this is one of the examples of the forest plot. Even if you don't write all these things, make sure at least to make this, right? So we have the line of no effect, and where you have two types of, one is probably favoring the study and the other is not favoring the intervention or whatever. Okay, so there are two groups, and we on the first side we have the individual studies, the number of patients with treatment and control group, and depicting the number of patients with the outcome with the total number divided by the total number of patients in the treatment and the control group. So the squares, which is the square which is larger, will have larger studies and a reduced confidence interval. So when there is a decreased confidence interval, the study is more precise compared to that of a confidence interval which is huge, as you can see. So this is one of the if you take these, this and this, right? So this is a more precise study. The confidence interval is smaller here, while the confidence interval here is huge, but look at the effect of the study. The weightage of the study is quite small, right? So, this is something which is depicted in this particular plot. And if the confidence interval is crossing beyond the line of null effect, right, then too much beyond the line, or if the weightage is crossing beyond the line of null effect, then the significance of the study comes down, right? And uh, the results or the interpretation of the entire study is given by the diamond, which is the diamond of the bunch. Okay, like we say, the diamond of the season. So we have the diamond of the bunch, which is given below, and this depicts the interpretation of all the studies. So in this particular example, you have it on this side, probably whether it is favoring or not favoring. So this is what it is favoring. This is what the diamond suggests. All right, and the scale of the statistic is displayed below, right? And the heterogeneity levels are depicted below this area where the individual studies are there. It is given by the chi-square or the I-square, and it depicts the heterogeneity of the study. Okay. And if it is more than 50%, as we have mentioned, then the studies are inconsistent. Interpretation, it helps to examine the individual studies. Statistical significance, we have mentioned it in detail. If the study's confidence interval crosses the line of no effect, then it is not statistically significant. Assess the pooled estimate. Diamond at the bottom helps to assess the pooled estimate. It gives a visual assessment and variable results across the different studies, and it helps to identify the trends across the various studies. Okay. Coming to our next topic, which is the funnel plot. A funnel plot, it is a scatter plot that compares the precision and results of the individual studies. It is commonly used in meta-analysis to visually detect a publication bias. So the term funnel plot, basically it is in the form of a funnel. It refers to the fact that the precision of the estimated intervention effect increases with the size of the study. Okay, a small study effect estimates will typically scatter more widely at the bottom of the graph, with the spread narrowing among the larger studies that are more precise and closer to the true effect. The plot should ideally look like a pyramid or a symmetrical inverted funnel, as seen in this image. So how are you when this kind of answer comes? So you have to plot a graph, all right, and you have to plot the studies. So each study is represented as this dot, and like the line of null effect in the previous slide, we have the line of overall effect here as well. And then you have this two, the triangle, and this represents the 95% confidence interval. All right. And all the studies are within this 95% confidence interval. So the y-axis is represented by a measure of studied precision. For example, a standard error. And the more precise studies are towards the top of the funnel, right? And the less precise studies are towards the bottom of the funnel. The x-axis will represent the estimate size of the outcome. It can be given by odds ratio, okay, or by risk ratio. So these are given by odds ratio or by risk ratio, and it is plotted in the form of a logarithmic scale. Or you can also use sometimes continuous measures like mean difference or standardized mean difference can also be used to plot the x graph. So x, y, and you have this funnel, and we have to see. So basically, it helps to uh, identify biases and heterogeneity in the study. So, if 95% of the study is expected to lie within the diagonally dotted line, all right, and we have and the confidence, so this is the 95% confidence interval. Implications. Example, we have these two images. One is an image A and the other is the image B. So here we have the standard error on the y-axis and the logs odds ratio on the logarithmic odds ratio on the x-axis. The line of no effect or the overall effect, and then the 95% confidence interval. What do we see here? We see here that the studies are multiply scattered in the different uh, directions of the study, right? So image A is like this, and image B depicts an asymmetrical funnel where all the studies are basically pushed to one side. Okay, so why is this happening? This is happening because probably there is a bias in the study. That's the reason why all the pointers are pointing towards the left. All right, and it gives a meta-analysis summary of the study. So here what is happening is the summary estimate will tend to overestimate the intervention effect. We know there is some bias as a result of which whatever the effect of the study or whatever the outcome of the study will probably overestimate whatever the intervention effect is. Okay, so the reasons for the asymmetry in a funnel plot could be there could be biases, publication, location bias, true heterogeneity. The size of the effect differs according to the study size. Okay, intensity of the intervention and differences in the underlying risk. There could be data irregularities, some fraud, artifact heterogeneity due to poor choice of the effect measure. Effect measure meaning you have to choose a proper effect measure. Okay, odds ratio, risk ratio, whatever, and it could be sometimes because of chance as well. So that cannot be helped. Okay. Next, we have the next topic, which is the number needed to treat and the number needed to harm. The number needed to treat actually had come during our FAT exam. All right. And actually, I couldn't write it properly, and I went back and read it after our FAT exam. So, number needed to treat exam. So the exam formula, I think this is a general thing which I wanted to say in the previous slide as well. Whenever a statistics question comes, write in this format: define, give the formula, give an example, interpret, and what are the limitations, if any, you know. Okay. So number needed to treat, why does it matter in critical care? So our RCTs often report the studies in terms of a relative risk, right? And but these are, clinicians do not need a relative risk, they need an absolute patient centered measures. So that's where the number needed to treat and the number needed to harm comes in. The number needed to treat is the number of persons who have taken the treatment, okay, for one person to benefit from the treatment. And number needed to harm is the number of person who has been exposed to the risk factor for one person to be harmed who would not have otherwise been harmed, right? So it is how many number of person you're giving the treatment to for one person to have the benefit, and how many number of person you're giving a risk factor or exposing them to a risk factor to have a harm to. So this is what number needed to treat and number needed to harm is. So number needed to treat is a reciprocal actually of the absolute risk reduction, while number needed to harm is the reciprocal of attributable risk or absolute risk increase. Okay. And it is more meaningful than the relative risk for assessing the efficacy of a treatment. So the relative risk is essentially a constant, it is constant regardless of whether the risk is there or not, but the NNT is likely to be higher in low risk group. Fine. So the importance, however, cannot be given just by one value. One needs to see the weight, the benefit, and the harm of the trials, the studies. For example, the number needed to treat in the Proseva trial was 6. Okay, this is a number again. Somebody might ask you, what is the NNT of the Proseva trial? The NNT of the Proseva trial was actually 6. So, what does it mean? It took 6 patients, okay, to find benefit in one patient with prone ventilation. So this is what it means. So the current concept that one needs to understand is the number needed to treat is 1 divided by absolute risk reduction. Number needed to harm is 1 divided by absolute risk increase. Okay. So the absolute risk increase, the absolute risk reduction is given by the controlled environment rate minus the experimental event rate. Absolute risk harm is given by experimental event rate minus the controlled event rate. And I'm sure by listening to this, you probably would not have understood a single word of it. So let's learn it with an example. Okay. So example, there is a new drug that has come for sepsis. All right. So we will be seeing the number needed to treat and the number needed to harm. Okay. So the new drug has come and it was found that in the control rate, the mortality of the drug was mortality was around 30%, but after giving the drug, the treatment rate, the mortality came down to 10%. Okay. So what is the absolute risk reduction in this patient? That is the controlled event rate minus the treatment event rate. Okay, that is what I said. The controlled event rate minus the experimental event rate. That is the risk reduction. All right, and that is 10%. So number needed to treat is given by 1 divided by the absolute risk reduction, which is 10 for this case. Now, adverse event. Adverse event, similarly, suppose this same drug causes a renal injury and the renal injury is 2% for a control rate, but in case of treatment, it is 5%. That is high, correct? So the basically the renal injury is experimental rate minus the controlled event rate. So experimental, the 5% minus 2%, that is given by 3%. So the number needed to harm is around 1 divided by 0.03, which is 33, right? So 33 patients were studied to cause harm to one patient, and 10 patients were studied to to find the benefit of the drug in one patient. So the weightage of which is more? Interpretation is the low number needed to treat is a more effective treatment and a high number needed to harm is a safer treatment. So we don't go by one number, we go by the net clinical benefit together. Okay. The pitfalls is they are time dependent. You do not know the interpretation or the adverse events or the protection benefit, whether it is for a year or 30 days or for 1 year, that you will not know. It cannot be homogeneous across all patients. It does not take into effect the patient risk factors. Okay, it does not take into account, does not account for the severity of benefit versus harm. They will just give a number. You have to interpret yourself. And wide confidence interval in small trials is less reliable. So they will be, if the trials themselves are small, then automatically these numbers won't matter. Okay, so I hope that you have understood the concept of number needed to treat and number needed to harm. Coming to our next topic, another very important topic, and you need to understand this concept very well, that is receiver operating characteristic curve and area under the curve. Okay, I will try to explain this conceptually so that in your own manner you can write in the exam. All right, this is what statistics is all about. So, the basic concept, how to draw the ROC curve, this might not be needed in exam, but you surely need to know what it is to even understand our basic statistics. The meaning of area under curve, methods for selecting the best cutoff value. Okay, we'll check this parametric and non-parametric ROC curves. We will not discuss this. It's not required. So, the ROC curve aims to classify a patient's disease state as either positive or negative based on the test results. It helps to find the optimal cutoff value for the best diagnostic parameter. It is used to evaluate the overall diagnostic performance of the test and to compare the performance of two or more tests. So, this is basically a curve which has a lot of benefits, as we have discussed here, right? So, before we jump directly into the ROC curve, one needs to understand the basics of how the ROC curve is formed. And that starts with sensitivity, specificity, the false positive, and the false negative. Okay, so we go with the decision metrics. The decision metrics, you have the disease positive state, the disease negative state, then you have the predicted condition with positive and negative state, A, B, C, D, and you have the the formulas for the sensitivity is the number of true positives, specificity is the number of people who do not have the disease who are tested negative, false positives who do not have the disease but are incorrectly tested positive, false negative who have the disease but are incorrectly tested negative. Remember that you have a separate statistics table in your vivas, and all these questions might be asked. So, these definitions are also important for you all. And the ideal test that we want to have is a sensitivity specificity which is equal to 1. Accuracy is given by A plus D, which is the all the truths divided by everything. So when a diagnostic test is performed, okay, so you have people without the disease, people with the disease, the false negative and the false positive. Suppose this is a graphical illustration and this is a cutoff, right? If I switch the cutoff from here to here, say, okay, from 60 to 55, this is my cutoff, say, then the number of false positives are going to increase and the number of false negatives are going to decrease. So how do you determine a cutoff in the patient? Okay, so it is uh, this is what is the basis of the ROC curve to determine what the cutoff is. The ROC curve, it is an analytical method which is represented as a graph. Okay, and it is a coordinated axis where you have the x-axis having 1 minus specificity, which is the false positive rate, and the x-axis with sensitivity. It is used to evaluate the binary diagnostic classification. Just you have to know whether there is a presence of a disease or an absence of a disease. The closer this curve is to the sensitivity area, suppose the curve is like this, okay, like this curve is better than this curve. All right, so the closer the curve is to the sensitivity, it is better, and it is closer to the sensitivity equal to 1. The most desirable property of the ROC analysis is that the accuracy indices derived from this technique, they are not distorted by fluctuations caused by an arbitrarily chosen decision criteria cutoff. All right, as we have discussed here, there is an arbitrary decision to take the cutoff as this or to take the cutoff as this. So the ROC curve helps to override that. And how does it override? So we have how the ROC curve is drawn. We have a decision matrix. Okay. So basically, we just choose a cutoff. Say 0.35 is the cutoff. We have the true positive, the true negative, the false positive, and the false negative. And we plot it in our decision matrix. Okay, so this is how we calculate the sensitivity and we calculate the specificity or the false positive rate. All right. Uh, Suppose we plot the same thing with different cutoffs. All right. Here we have the cutoff as 0. If we have taken the cutoff as 0, all the patients are true positive. Well, all the patients are diseased basically, right? All the patients are diseased. So if we have taken this as the cutoff, all the patients are diseased. So 10 on 10 patients are have a false positive rate that is equal to 1. True positive rate, 20 on 20 patients are having a true positive rate that is 1 by 1. So your at the end of the day, your T is equal to 1. T is nothing, but you are determining the true positive rate and the false positive rate and the ratio of them. Okay. So if the cutoff is 0.35, then your false positive rate and your true positive rate changes. Likewise, if your cutoff, you keep increasing the cutoff, right? Your number of true positives will come down and your number of true negatives will increase. So basically, your sensitivity decreases and your specificity increases. Okay. So these numbers, the false positive rate and the true positive rate, they decrease as the threshold grows larger, right? So what we do is we plot each of these, whatever cutoffs we get. Okay, this is arbitrary. Whatever cutoffs we get, we plot them in a graph. And this is how and we just plot this in the graph and connect all the dots. So there we get the ROC curve. Okay, this is how we get the ROC curve. And the area below this is nothing but the area under the curve. Okay, this area under the curve effectively measures the sensitivity and specificity of any diagnostic model. And the higher the area under the curve, we said the ROC curve which is near the sensitivity is better, right? So the higher the area under the curve, it is a better model compared to that of anything which is lower down. So area under the curve, it is given by the ROC probability curve and it represents the degree or the measure of separability. It is widely used to measure the accuracy of the diagnostic tests or two binary classifiers. When the best one is the area under the curve less than equal to 9. Okay, zero point 0.8 to zero point 0.9, it is good. Ideally, it should be kept at least a minimum of 0.5, but at least a minimum of 0.7, so that is fair. Anything below 7.7 is not a good ROC curve. The interpretation will not be good. Okay. So we have what we have studied right now. If we recap, we have plotted the ROC curve. We have gotten the area under curve. But now the question remains. What is the question? The question was, how do we find a cutoff value? For example, I want to find the best anti-pro BNP cutoff. How do we get anti-pro BNP cutoff for the age of the patient or for a ACS patient? How are we going to find a cutoff? So we plot the ROC curve, all right, and then we determine how. So from the sensitivity point, you draw a perpendicular to the ROC curve. Whatever the point is available, that gives the best cutoff for that particular ROC curve. All right, the point on the this is the point where the sensitivity and the specificity is the maximum. So this states the the best cutoff. Apart from that, there are other things, there are other parameters which are available to determine the cutoff value. You do not need to know, as long as you know this, that a perpendicular is drawn from the ROC curve, from the sensitivity point, the high sensitivity point, to the ROC curve. This is the point of best cutoff. Okay, and there are other indices like Uden's index. Then you have the point on the curve with the maximum distance from this 45-degree line. Okay, these are also the other parameters. Only one of these, if you remember, that is good enough. Advantages: it is simple and graphical. It represents the accuracy over the entire range of test. It is independent of prevalence. The tests may be compared on the same scale and allows comparison of accuracy. The disadvantages are actual decision thresholds are not displayed on the plot. And as the sample size decreases, the plot might not be the same. You might not get a a straight plot. It might be all zigzag if the sample size is small. Calculation is cumbersome, and friendly flexible software is not widely available. So these are the disadvantages of this curve. Coming to our next topic, which is the standard deviation and the standard error. So this was also one of the questions in the last exam. Okay, this was in fact, I remember the first question that has come in our first paper of the last exam. And the standard deviation and the standard error both measure variability. High values of either statistic indicate more dispersion. Standard error is not the same as standard deviation. Okay, so basically, standard deviation quantifies the variability of values in a data set. It assesses how far a data point falls from the mean. Okay. And standard error is what it quantifies the variability between samples drawn from the same population. How accurately a sample data represents the whole population. That is what a standard error depicts. So, example for a standard deviation. So, suppose we imagine there are a set of random 10 people and you are measuring the IQ of these 10 people. Okay. So when we are measuring the IQ, we get a mean, which is the red diamond here. All right. So what is the standard deviation? How much are the values of the individual test which are deviating from the mean? This is nothing but the standard deviation. Okay. Now, this is one of the tests for 10 people, right? Now we have multiple of these tests of say 10 people, 15 people, multiple of these tests, and we plot the mean of each of these tests uh, in a paper, right? So we get means of individual tests. Okay. So if we connect all those individual means together, then we can get what is called as the standard error. Okay. So this standard error, it depicts the variability. More specifically, it assesses the distance between each of the data point from the sample mean. Standard deviation can be interpreted by using a normal distribution curve, which is the bell-shaped curve, and in any normal distribution, data will not be symmetric. Data is symmetrical and is distributed in fixed intervals around the mean. In terms of standard deviation, if the graph you have a high narrow peak graph and a small spread, that means the standard deviation is low. And if you have a flatter curve with a longer base and a broader peak, that means you have a higher standard deviation. Normally this is what you should know. Empirically, the rule what it states, around 68% of your values, they fall within the first standard deviation. Within the second standard deviation, you have 95% of your values that fall, and within third standard deviation, you have your 99.7% of the values that which fall, which are the standard deviation of the mean. Coming to the standard error, as we have defined earlier, they are often referred to standard deviation, standard error of the mean, and it is a measure of precision of a sample statistic, typically the sample mean. Definition: the standard of standard error, the standard deviation of a sampling distribution. As we said, in a standard deviation, we are taking a single example, say 10 people, you go for a mean. But in a standard error, multiple of those means are taken and a sampling distribution is created. Okay. To estimate how much sample means would vary if we repeat the sampling process many times. So the formula is standard area. The standard error is equal to standard deviation divided by root over n. The SD is standard deviation of the sample, and n is the sample size. As the sample size increases, the standard error decreases, and the standard deviation remains constant regarding the sample size. So, sample size is the standard deviation will remain the same, but the standard error changes. While standard deviation measures the spread of the individual data points, the standard error estimates how precisely the sample mean represents the population mean. So differences what we have, the standard deviation is within a data set. Standard error is across the samples or between the samples. The standard error, the standard deviation measures the data dispersion, while standard error will tell us about the mean precision. Okay, multiple means and which is the most common finding, that is the mean precision it determines. And it assesses, the standard deviation assesses the distances between the data values and the sample mean, while standard error assesses the distances between the sample statistics and the population parameter, that is the accuracy of the study. And as the sample size increases, there is no change in the standard deviation, but standard error has a tendency to decrease. All right. Coming to our last topic, which is the parametric and the non parametric test. So, in parametric and non parametric test, there are two broad families of tests to analyze the data. We have the parametric test, which assumes a normal distribution, the normal distribution, and non parametric, which is distribution free. That is, they are more flexible when assumptions fail. It doesn't follow the normal distribution curve. So think of them as parametric is ideal condition. You have the bell-shaped curve, you have all the data set within the distribution. Non-parametric is the real world, which is the messy data, and you have to go accordingly. So parametric tests. So parametric tests for a single sample, we have the t-test and the z-test. For two samples, we have for individual sample, we have the two groups, the t-test and the z-test. For paired sample, you are doing a paired t-test. For non-parametric test, for a single sample, you are doing chi-square, the cross-weld, the KS test, the runs test, the binomial test, and then you have the other tests like chi-square, Mann-Whitney test for a two-sample test. Okay. So, what I want you to concentrate is on this. So, if you know this, you will be able to write something about parametric and non parametric tests. And this was also one of the questions in our last exam. So, when there are two groups which are independent, normal, for a normal curve or the parametric tests, we usually go for independent t test. For non parametric, we go for a Mann Whitney test. If there are two groups which are paired before versus after, say, you go for a normal distribution, we go for a paired t-test. And for a non-normal distribution, which is the non-parametric, we go for a Wilcoxon sign rank test. If there are more than two groups with independent measures, okay, we go for ANOVA test for the normal distribution curve, and we go for a Kroskal-Wallis test for a non-parametric test. For more than two groups, if there are repeated measures, you again go for repeated measured ANOVA test. For a non-parametric test, you go for Friedman test. And correlation studies, Pearson's correlation is used for a normal distribution curve. For non-parametric tests, you go for a Spearman's rank correlation. Coming to the t-test. T-test, as we have said, we need to know whether it is an independent test, whether it is a paired test or what. So example, we'll just take with the examples. So one sample t-test, it compares the mean of a sample to a no or a reference value. For example, what is the mean hemoglobin in the anemic patient, which is significantly different from the WHO cutoff of 12 gram per dl. You have a sample, you want to know what is the mean of the anemic patient or a group of anemic patient, mean hemoglobin in the anemic patient in that particular group, then we go for one sample t-test. Now, unpaired t-test, you are comparing two independent groups. For example, you want to know the systolic BP decrease or increase with a drug test A or a drug test B, right? You have two individual groups, two independent groups, and you want to test a particular parameter, which is an independent parameter for the two groups. Okay, then you go for an independent t test. Coming to a paired t-test, it compares the mean in the same group before and after intervention. For example, you want to see an HbA1c levels in diabetics, okay, after a new insulin regimen. So before and after, you'll have to check. Then you go for a paired t-test. So I hope the examples are very clear, okay. And then we come to ANOVA test, which is the analysis of variance test. It is used to compare three or more groups. All right. So it compares, suppose a patient uh, is on three different types of diet. All right. One is on a fasting diet, one is on a keto diet, one is on a normal diet. And you want to know the mean cholesterol levels across the three groups. Then you use an ANOVA test. For one factor, you will use one way. For different types of diet, with say you're adding a gender, then you use a two-way ANOVA test. And if the same group you are measuring multiple times, then you use a repeated measure ANOVA test. Chi-square test, it tests the association between categorical variables. Okay, this is a non-parametric test and you use it for categorical variables, whether smoking status is present or absent, and it is associated with a lung cancer, which is present or absent. Okay, so in fitness tests, blood groups also you can use it. Mann-Whitney test, it is an alternate to the independent t-test, as we have seen in the first in the second slide, it is alternative to the independent t-test when the data are not normally distributed. Examples, it compares the independent groups on the ordinal or continuous data groups, but the data is skewed. For example, you are comparing the pain score 0 to 10 scale in patients on two analgesics. Okay, you have you give one analgesic and you're comparing, and you give another analgesic. So analgesics, basically pain, you might not have a number. You will have patient is having 0 to 10 score, but he will tell I have 0. It is a subjective number. So in these tests you use the Mann Whitney test. Okay, so this is the last slide